So with this, let me start the webinar and let me welcome our chief guest, Dr. Sangeeta Reddy, who is the Joint Managing Director of Apollo Group of Hospitals. And Apollo, let me introduce, is the biggest chain of healthcare and second biggest in the world, biggest in the Asia Pacific region. We have 70 state-of-the-art hospitals apart from a huge network of Apollo clinics, Apollo pharmacy, diagnostics, insurance. So it's a big, very big healthcare chain. And now going into IT, AIs, and Dr. Sangeeta is going to be talking about it. And let me also welcome the chairman, Dr. Jacques Busquet, who is not only a very ace angiologist and a vascular surgeon from France, he's also been the president of the International Society of Endovascular Specialists, and he's on the editorial board of Journal of Endovascular Interventions. And also, he's been an athlete and he represented France in the Olympic team. We also have Kate Drake from Corindus from United States. We will be joined by Dr. Jean Fajade, who is the very world-renowned interventional cardiologist, president of the EuroPCR meeting, who would be showing a recorded case of endovascular robotics for coronary interventions, complex coronary interventions. And then we have Dr. N. Subramaniam, who is the Director of Medical Services at Indraprastha Apollo Hospital, a very accomplished urologist and endourologist, I would say. So let me welcome Dr. Sangeeta Reddy and Dr. Jacques Busquet. I would also like you to please welcome Dr. Sangeeta Reddy, our Joint Managing Director.
It's a very big honor for me to be with you today and a real pleasure because I'm speaking with some friends that I love very much. Like you, Dr. Khanna, you are one of my models. You are one of the best specialists in endovascular technique in your region and in Asia Pacific area. And I've been very proud with Dr. Dietrich, our former master, to support your meeting, which gather more than 2,000 or 3,000 people. We start with 100 or 200, so congratulations. In terms of equipment, I can tell the public that you deserve this program because you are working a lot, you are working well, and you are working in a modern fashion. So I encourage your investor to play the game with you, and I will be very happy to give my presentation later on and answer your question. And please be numerous to ask questions. We are ready to answer you.
Thank you very much. So Dr. Sangeeta has to leave for, she's also the president of the FICCI, which is a very prestigious position in terms of the Federation of Indian Industries. And she, with a lot of, we are very honored that she could take out time. She has to leave by 5:20. So I'll be requesting her to give her presentation on adoption of innovation towards improving medical care. And as we know that Apollo has always been on the cutting edge of technology on introducing the latest technology in Asia Pacific region. And not only that, it caters to the need of our Indian patient, but it caters to the need of international market at a very affordable price and good quality, international quality treatment. Thank you very much, Dr. Sangeeta Reddy, for joining us.
Good evening, everyone, and good morning and good afternoon from people from other parts of the world, but also namaste. I think namaste is the greeting that India has given the world, which is becoming more relevant now in COVID times. Let me first begin by saying how happy I am that you're continuing with your conference and that everybody is finding ways to stay safe and move ahead in these very difficult times. Dr. Khanna, it's a pleasure to be part of your program. We must acknowledge the fact that you're not only one of the most popular and well-known endovascular and peripheral vascular surgeons, physicians, and you run the most popular program, but this program also, the educational one, attracts patients from all over the world and international doctors for training, and you've been doing this for the last 10 years. Our founder, Chairman Dr. Pratap Reddy, had encouraged Dr. Khanna to start the Asia Pacific Vascular Intervention course along with Dr. Michael Henry at Indraprastha in 2009. And like Dr. Jacques Busquet was saying, it has now grown tremendously, which is only a reflection of the tremendous physician he is, and the fact that I think at his heart, he's also a great teacher. So he manages to combine both the passions. Dr. Busquet, Dr. Jane, Dr. Kate Drake, and Dr. Jean Fajade. It is a pleasure to share a platform with you. And I truly acknowledge your presence and thank you for your kindly sharing time to do this teaching and training program. Dr. Subramaniam and Dr. Khanna, again, congratulations for putting this together. It is, quite significant for us, the times that we are in, to really acknowledge the role of innovation towards adopting medical care. And in medical science, actually the entire science is a war that never ends. Viruses arrive, they mutate, new pathogens emerge, and honestly, no one can really predict the future. And humanity has realized this definitively as it continues to combat with SARS-CoV. Yet on the brighter note, the silver lining has always been about innovation. It's about how healthcare, and more important, about the humanity in healthcare, who stand up and say that we will find a way to fight, we will find a way to overcome because our patients deserve it. And it is this spirit that creates dramatic improvements in health and wellness. It is this spirit that inspires small nurses to brave the COVID virus, even though they know that some of their colleagues have succumbed. It is this innate sensibility that physicians and healthcare people reach out to serve. And I first want to celebrate this. I want to thank all healthcare workers around the world for the great sacrifices that they and their families are doing. I want to honor those who have lost their lives and acknowledge those who continue the battle. And added into this acknowledgement is scientists, innovators who find ways to make the tests more rapid, to innovate on biosurveillance, on biosterilization. Everything is taking a new path, whether it's even in production. India was a country that produced only 10,000 PPEs a day when COVID began. Today we produce 400,000 PPEs a day and are now a net exporter of this product. The same for the great race towards the vaccine. So I think we should acknowledge, appreciate, and continue to celebrate this spirit of service to humanity and of innovation so that we can share more. On that note, I think rarely a day goes by when we don't come across a new innovation in healthcare, and everyone is chasing. But what are they chasing? They're chasing higher quality, greater access, better cures. But ultimately, I think what we need to be chasing is how to keep the population healthy first. And then if there's a problem, how do we cure it? And at another end of this spectrum, in equal pace as healthcare people, are now the new rise of companies like Amazon and Google, who are trying to say, let us begin to look at this race. So whether they're using artificial intelligence models or using patient communication and education interventions, all of us need to find ways to work together towards this joint goal. But either way, I think the digital space is beginning to get some tremendous attention. I'm pleased to be participating in the intervention of clinical, digital, and machine, because innovations in the role of robots are redefining endovascular, vascular interventions. And like Dr. Khanna said, it enhances precision. It enables the same quality of care through distance. And if you apply some of these principles, in addition to the fact that there is indeed a global shortage of quality and skilled people, this would enable remote interventions. So I can visualize Dr. Khanna in the next 5 to 10 years managing one of these robotic endovascular machines, but operating in 20 countries without leaving Delhi. And this will happen. A combination of equipment, bandwidth, the 5G is around the corner, all these will enable this. And while historically operating rooms, which are the most critical area in a hospital, were said to be, areas of low degree of technology savvy, but that was a decade ago or maybe more. They were about surgical lights, simple operating theaters, and some surgical devices. Today, the transition has made that there are robotic surgical systems, and Apollo was an early adopter in surgical robots, and we continue to look at how surgical navigation systems will change and project and enhance access and reach, minimize bleeding, perfect surgery even further, and yes, can be used remotely. I think cutting edge processes like this are being seen across the spectrum. So when we began in 1983, we were quite privileged to bring in among the early machines, whether it was the advanced CT scan. And yesterday, our health minister launched a 640 slice CT, which can look at calcium scoring and therefore do risk prediction. And if we combine the machine with an artificial intelligence risk prediction model, which we have actually created along with Microsoft, using about 1 million records of our health checkup patients. Imagine the transformation. And I want to share this with all of you for a minute, because this is a virtual meeting and a congregation of brilliant minds. I want to take this opportunity to share this perspective. And that is that healthcare today is a scenario of patients coming in. It's about sick care. It's about the doctor's opening line being, what seems to be the problem today? Imagine if we did not have to look at those problems after they were full blown. And Dr. Khanna will bear me out on this, that 60 to 70% of cardiac interventions happening across India are patients who need 2 to 3 either bypass in their vessels or intervention to unblock and add a stent. The question we also need to be asking, and we've asked this question, so how do we get better cath labs and do angioplasty and do rotablator and then stents and then drug-eluting stent and then, now you're talking about vascular intervention and TAVI and TAVR. So that evolution is happening on one side. At a parallel level and at an equal pace, the question to be asking is, where was that man when he had his first block? Where was that man when he had his elevated cholesterol and his high blood pressure and his bad lifestyle and he was building up that block? And how do we use calcium scoring and artificial intelligence and biochemistry and health checkups to be more proactive and preventive about healthcare? So this is, I think, one of the big changes which is happening, while simultaneously technology and digital interventions are enabling things like proton therapy. And in Apollo, we've been able to bring the first proton machine into Asia so that we can do more precision medicine. It is enabling the interface between genetic knowledge and intervention. It is bringing in these capabilities of biology, bytes of processing, and bandwidth of connecting the world. And these 3 Bs are indeed transforming. So I want to congratulate all of you who are driving the engine of curing and caring, who are fueling the absolute capability of innovation and new solutioning, and using this engine of creativity to bring better solutions for your populations and the world. And finally, I want to just congratulate you by saying that this journey will not end. We will keep at it. And this journey will be more and more meaningful as we reach more and more patients. So Dr. Khanna, I wish you and your entire tribe of everyone who is striving the very best. I congratulate all of you for the multiple lives you've saved and the many people who you've taught how to save lives, because you've had an indirect hand in the treating of so many people by training itself. And I will end by once again respecting and acknowledging clinicians and doctors, because you are the only ones in the world that when you invent or find a new technique, the first thing you do is write a paper. The second thing you do is speak at a conference. What does every other industry do? When they find something new, the first thing they do is they protect the IPR and say, how can I make money off this? So please protect this beautiful capability of doctors. I wish you the very best. On behalf of Apollo Hospitals, I commit that we will leave no stone unturned to support our clinicians, to support our doctors in delivering the best of care for your patients. All the very best, and my grateful thanks for this opportunity to interact with you. Namaste.
Thank you very much, Madam. We are really honored by your presence and by your guidance, and we'll continue everything to get Apollo's and the top. We are at the top, we'll keep it at the top. And let me also tell you, Dr. Busquet has been a fighter of, he got Corona, he won over the Corona, and he's back to work. So he's a real Corona warrior and back to work, and he's very actively involved in his clinic again. Thank you very much for sparing your time, and we are really honored. So thank you so much. So we'll move on to the next presentation, and we'll invite Dr. Jacques Busquet to actually, lay a preamble and about the robotics, vascular robotics, what it is, and what is the need in this present era, and how we are going forward in this technology. So Dr. Busquet, please.
Thank you very much. Thank you very much for this good first talk. Who put in advance your position, and congratulations again. When I start my training in endovascular technique as early, next slide, Mr. Khanna, please. Next slide, if you can send my slide.
Just we'll load up your slide.
When I first start my training in endovascular technique, it was as early as 1988 in Phoenix, Arizona, with Dr. Dietrich. We start with an X-ray machine with some guide, some puncture, some balloon, and we discover the stent. The machine was an X-ray, sometimes a C-arm, and progressively we moved to a room. Next slide, if you have, Dr. Khanna. My first slide, please.
Just give me 1 minute. It's just loading up.
Okay. And this room, this endovascular suite, progressively move to a better system, better source of X-ray. But it was not protective at that time. Then we moved to the injector, to have the global cartography of the arteries in one shot. Then, more recently, we had the IVUS, who was a system to see inside the artery. And now, finally, we have this robot with the precursor of a totally automatic procedure, just led by the surgeon of the endovascular specialist from the back of the room, with a higher precision, with a reduction of the dose of contrast when you inject, and a more rapid procedure with much more precision in the catheter guiding. Anyway, I am really approving this new technology, and I congratulate Dr. Fajade, who is one of my colleagues and friend, to use this system. They are very well known in the practice in France, and this will be hopefully the best way to treat our patient. You know, we have the Tesla car without a pilot, and it seems to work well in the first test, no crash. And we can compare our procedure to this car without pilot. And the aim is to achieve our procedure with less trauma, less invasivity, less contrast, and less material. So I just hope to get one as soon as possible. I know it's something which represents a certain amount of money, but in a very big workload center, it will be something natural to get this system. So I really tell all the public to go to this technique, but you have to be in a good collaboration with your colleague, surgeon, radiologist, cardiologist, and work in the same way for the best treatment of patient. This is on this slide, the ideal room. The endovascular specialist is in the back. It's just selecting the best images once he's traveling his guide inside the artery without exposing himself to the X-ray. So next slide. And then I would like to give some advantages. If we can move on the next slide, Dr. Khanna, it will be good. You see all the sequence of working. You can move the table. You can also do fusion. And the robotic is something else that helps very much. You had to be aware of all the techniques to use it, and probably the Siemens group can do that for you on site. I would like to go on the next slide. This system make a better visualization, a faster procedure with some intelligence and automation, I should say. And the benefit is total for the patient. I know that we can do it in some very good center, excellent center, like you, Dr. Khanna, in the Apollo Center in New Delhi. And protection, precision, standardization, and proven outcome are the word to not forget in this type of demonstration. And finally, my last slide, not to be too long, it's a very simple conclusion. The angio robotic is, in my mind, the future. It will give precision, reduction of dose of contrast, less X-ray, so sanitary protection for the doctors, and faster procedure for a better outcome. Thank you very much, Dr. Khanna, to give me the privilege to speak with you today.
Thank you very much, Dr. Busquet, to set up the stage for robotic endovascular interventions. Let me invite Dr. N. Subramaniam, who is our Director of Medical Services. He's a very good endourologist and a very ace, medical administrator. He would be just speaking on technology innovations and in healthcare. So, Dr. Subramaniam, thank you for coming and joining us. We are honored by your presence, and we'll be delighted to hear from you. Can you, Dr. Busquet, your screen has to be put off the share.
You want me to put off the
screen share?
No, so I was sharing the screen. The screen is already being put off.
Okay.
Is that okay?
Yeah, it's okay. Dr. Subramaniam, can you hear me? You can please start your presentation and share your screen.
Thank you, Dr. Khanna. Let me begin by thanking you for the opportunity and for congratulating you for this wonderful program that you've organized today. Dr. Busquet and all your colleagues who are into such high-end, cutting-edge technology work, I really appreciate the wonderful work that is happening. We heard Ms. Sangeeta Reddy speak so eloquently about the value of technology, the value of innovations, and how it helps to keep the world happy and healthy. Let us look at a slightly different dimension. I mean, the fact that you and I are in a meeting today during the COVID era is a clear example of how technology has not only helped us continue with our academic work and sharing of information, but we are in a position to share it with much larger audience, with very eminent speakers from different parts of the world coming together, thereby making sure that we have the best information that we can share with everybody. As a urologist, I have always been passionate about endourology to begin with, and then later robotics have been an integral part of uro-oncology in the last 20 years or so. So I think when I see the combination of robotic and endovascular and cardiac work happening, to me, it's an immense amount of joy. I just want to step back into a more basic fundamental. You and I are very clear, whatever be the disease and whatever be the treatment, the best outcomes come with early diagnosis. And if it is minimally invasive, it becomes even better. So that people are aware, people are willing, and hence you diagnose several conditions early enough. In the general practice of life, you know the availability of biomarkers, the availability of immunohistochemistry, the availability of precision biopsies, the availability of advanced MRI and even virtual biopsies have all helped to create more specific and very early diagnosis. Having diagnosed a given condition, obviously when you come to the treatment, again, we are looking at the options of number one, which is the least invasive treatment. Where is a recovery most likely to be the quickest? Which is associated with the least amount of pain, the least amount of immobilization. And lastly, when it comes to the following up of the outcomes, we know that technology in the form of, again, biochemical markers, in the form of advanced scans, and in the form of least invasive methodologies provide the best kind of results. When you come to the element of the vascular and cardiac work, we are all familiar with the old-fashioned procedures which have really stood the test of time, be it the coronary artery bypass graft or going on to the off-pump grafts, to the mid-cabs and T-cabs, and more recently going on to the more newer technologies like the percutaneous and the transseptal procedures like the TAVRs and the mitra clips, etc., which are predominantly image-guided. Similarly, we know that the assistance of the robotics, which has been very useful in the endoluminal interventions and also in the abdominal aortic aneurysm repairs, etc., has also been extended very well to the minimally invasive method of treating renal and splenic aneurysms as well. We are also very aware of the methods of electromechanical and magnetic control, which are robotically controlling endovascular procedures as well. So I think the biggest benefit, the biggest benefit of technology would be, I think, in making sure that if one were to be contracting any disease, we are able to detect it at the earliest possible level, treat it by the least invasive methodology, and ensure excellent outcomes with the least amount of interference to one's life. So to me, that is not only the technology, to me it's a philosophy. And I think that is what takes you and I forward. And I must compliment you on taking up such a challenging responsibility of not only focusing on advances in technology, but also making sure it gets disseminated to all concerned. Lastly, the value of making any service, procedure, or a facility available to remote areas, and also use networks to the benefit of the largest percentage of mankind, I think is the greatest achievement of any technology. So let me wish you and the eminent team of experts wonderful deliberations. And I certainly am very grateful that I could be a part of this. Thank you very much.
Thank you very much, Dr. Subramaniam. We are really honored, and especially, you could squeeze 10, 15 minutes for us. It has a lot of meaning to us, and we are very encouraged. And with your leadership, I'm sure Delhi Apollo is going to be leading not only the Apollo group, but the healthcare in the northern part of the country and maybe the entire country. Thank you very much for your insights.
Very grateful. Very grateful.
Thank you so much. So I will next move on to invite Crate. Crate is from Corindus. She would be talking about the endovascular robotics, the concept, the machine, how it works. And she's going to show you some real cases on the machine and give you the concept of endovascular robotics. This would be followed by the case by Dr. Jean Fajade from France. And that will be really interesting to actually see how the robot works and how the precision medicine works in endovascular interventions. Over to you, Kate.
Thank you, Dr. Khanna, and thank you for having me as a member of the panel. I'm very honored to be here with all of your distinguished guests. As Dr. Khanna mentioned, my name is Kate Drake. I have been a proud employee of Corindus for 10 years. So I have seen endovascular robotics from its infancy all the way through where we are today, and excited about the future of vascular robotics that the Apollo Hospital System has already invested in. So today I'll be talking to you about endovascular robotics, primarily our existing CorePath TRX system, as well as the future and what that might hold. So a little bit of history about Corindus. We have actually been around for most of the 2000s, being founded in Israel back in 2002 by an engineer and an interventional cardiologist who sought to identify and create a safer working environment for physicians. Since then, we have had two different versions, two generations of our technology that have been on the market, the first of which was called CorePath 200, which received clearance in 2012, initially by FDA, and then subsequently our second generation technology, CorePath TRX, which received FDA clearance as our first indication in 2016, and then has subsequently been expanded and is now in many countries around the world, including India, which was an early adopter of our technology. In addition to developing our existing robotic platform, we as Corindus have invested quite a bit of our time and our engineering energy into the development of future technologies that could truly transform care. And some of those areas that I'll speak to you about today are remote interventions as well as automation. And the first time that we ever demonstrated remote interventions in 2017 showed feasibility, and then Dr. Tejas Patel was actually the first physician in the world to ever perform truly remote interventions in coronary intervention patients in 2018. It was a historic moment for us and truly for India as well, where 5 patients were successfully treated by Dr. Patel, who was located in a temple 32 kilometers away from the hospital where the patients were. In addition to that, we have continued to expand our indications, starting first in the heart, moving into the peripheral vascular space, and our next frontier will be neurovascular. And we completed our first robotic-assisted neurointerventions in 2019 in Canada. So we're very excited about the future of our technology, how we'll be able to apply it across the different vascular beds, and how we'll be able to take new innovations in order to expand access to care, improve standardization of treatment, and ultimately improve patient outcomes. It's truly a topic that has garnered quite a bit of interest, not only in the media, but as well in publications. The first in human report that Dr. Patel performed that study was published in a Lancet journal, and most recently, within the last couple of weeks, Corindus was featured for our work with remote technology development in a documentary that was made by Verizon, highlighting visionaries for 5G technology. So we believe that this type of innovation is going to continue to grow in advance in healthcare, and we are one of the companies that are leading the way. Now, when we think about interventional procedures, there has been a tremendous amount of innovation in the devices that are used to treat patients and the techniques that are employed in order to perform procedures. But the way the procedure has been performed has remained largely unchanged since the first angioplasty procedure was performed by Dr. Grunsig back in the 70s. That's until, of course, we introduced CorePath robotic-assisted platform in order to fundamentally transform how these procedures are being performed and provide tools for physicians in order to provide protection, precision, and standardization. This is what the CorePath GRX system looks like in a cath lab. We have 2 main components, which I will actually show you today. I'm here in our Experience Center in Massachusetts in the United States, and I'll be able to show you the system in action. There's a bedside unit, which is where all of the devices are loaded during the interventional procedure, and then an interventional workstation, which can either be positioned inside the room or in the adjacent control room that allows the operator to robotically manipulate their guide catheters, guide wires, and rapid exchange catheters during the interventional procedure from a radiation shielded position with all of the imaging up close in front of them. When you compare a robotic assisted intervention to a manual intervention, you'll find that robotics can add value throughout the procedure. Not only does it provide a safer working environment for the operator with the potential to improve the safety profile for both staff and patients, it also provides a level of robotic precision that can support the different parts of the procedure. You have up-close ergonomic visualization. We have developed automated robotic techniques that can potentially improve standardization of navigation, lesion crossing, delivery of therapy, and even measurement. The robotic system can measure to the sub-millimeter versus a visual estimation of lesion length, and then position devices with 1 millimeter accuracy. And finally, all of the devices are held inside the robotic system during a procedure, enabling them to be fixed and ensure that when you move a device 1 millimeter, it truly only goes that 1 millimeter. As I mentioned earlier, we got our start in coronary interventions in 2012, and since then, we've actually done over 8,000 procedures in the coronary space. Subsequently, we received clearance to do peripheral vascular intervention, and our focus in these procedures has been on those types of cases where the devices are very similar to PCI, so below the knee, renal procedures and the like. And then as mentioned, neurovascular is truly our next frontier. We've performed our first neurovascular procedures and have just begun a post-market registry for neurovascular in Europe, where we seek to gain additional data on the use of our system in aneurysm procedures. But ultimately, what our team in the R&D department is focused on is this opportunity to be a potential disruptor to stroke treatment, which is currently being undertreated through remote access capabilities. As part of the work that we have done, we have invested quite a bit into clinical evidence for the robotic system as well. We have seen in studies that the system can be used in very complex PCI with good success rates of 99.1%. Our pivotal PRECISE trial showed that the robotic system can reduce radiation exposure for physicians by 95%. Most recently, a study that was completed by Dr. Tejas Patel at the Apex Heart Institute in India demonstrated that the system could also reduce radiation exposure to patients by 20%, which is a significant reduction in radiation. And then due to the robotic precision of the system, the measurement capabilities and the positioning capabilities, the system may also be able to reduce measurement errors, need for extra stents, and geographic miss. So there are benefits across the board, not only for operators, but for patients as well. Our technology development roadmap has many different focuses, but two of the core areas that we are very focused on right now are automation and remote capabilities. And automation is something we have been really targeting towards PCI. As many of you know, procedures these days are becoming more and more complex. And as procedures become more and more complex, they can take more time. And a high percentage of time during procedures is often dedicated simply to navigating through the anatomy. Much of the work that's being done is trial and error based on what may have worked in the past. And these longer procedures can result in things like increased radiation or contrast for patients. So our strategy has been to create algorithms based on the techniques of highly skilled physicians across the world and design movements for our GRX platform that are targeted at improving lesion crossing, delivery of therapy, and navigation, with the ultimate goal of improving the efficiency and standardization of procedures and hopefully improving patient outcomes as well. We have one movement in the automated series called Technique that has already been in use for several years. It's called Rotate on Retract. We saw in a preclinical study with this movement that we could reduce wiring time by 53% and variability between operators. And we have a second set of Technique automated movements that will be coming out shortly. They are spin, wiggle, daughter, and constant speed. Spin and wiggle are navigation techniques with the wire. Spin specifically designed for lesion crossing, wiggle for navigation. Daughter is a device movement to enable lesion crossing and delivery of therapy. And constant speed allows the user to select a specific speed at which to move the devices. But I'd like to show you two examples of spin in action because I think they can be very powerful. In this first example here, this is someone wiring a type B2 lesion in a coronary flow model without automation. And then the second video will show with spin enabled. So I'll start the first video. What you'll see is that it starts okay, but eventually the wire gets caught up. It's prolapsing. The guide catheter actually backs out quite a bit. And what I'll do is I'll start my next video because it takes a little while to get to the point when we start to cross. But once we begin, you'll see that the wire just goes effortlessly through that lesion and has crossed in about 6 seconds versus the 25 seconds that this one took. And then in this second example here, again, this is without automation on the bottom left-hand side. You can see lots of prolapse. The guide catheter is backing out. This is probably not too uncommon of something that you might see in the lab. And then this example on the right is with automation and spin. And you can see that it beats the first example. So this is what we believe the power of automation can do, is not only improve that efficiency and speed up procedures, but create this level of standardization based on techniques of highly skilled operators. The second pillar of our technology development roadmap we've been very focused on is remote capabilities, or telerobotics. And both for heart attack and for stroke, there's a significant need not only to treat patients quickly, but to reach more patients. Right now, access to the skills needed in order to perform these procedures, these physicians who can do these procedures, is limited geographically. PCI specifically in rural cases, but stroke is truly a worldwide problem. And our strategy has been to develop remote technologies in order to reduce time to treatment for these emergent procedures, increase access to care globally, and expand the number of facilities that can perform these procedures by employing remote technologies. We believe that remote intervention can take many forms, though. Today, we see physicians that are either in the same room in the cath lab with a cockpit to manipulate devices robotically, or in the control room as shown in the image previously, and this is Dr. Fajade, whose case I will present to you today. But we also see that this could be deployed in order to create multiple room control within a single hospital, or truly remote control from one location to another. And we've demonstrated in most recently a simulated case series that this can be done not only from a few miles away, but from thousands of miles away. Dr. Ryan Mader of Spectrum Health in Michigan in the United States demonstrated this with 36 simulated robotic PCI procedures, where he performed from Massachusetts to New York, which is approximately 200 miles, and from Massachusetts to California, which is approximately 3,000 miles. And this showed great success and demonstrated the feasibility of these types of procedures, and the fact that, as stated by Dr. Reddy earlier, Dr. Khanna truly could be performing procedures at some point in his career in different countries and not just down the street. So I will now transition to demonstrate the technology for you. And I have my colleague here with me in order to help me out. Okay. So we're here in the Experience Center at our headquarters in Massachusetts, and I have a CorePath GRX system set up here for you. Over on this side, you see the bedside unit. This consists of an extended reach arm, a robotic drive, and then a single-use cassette that's loaded on top of the robotic drive and houses all of the devices during the interventional procedure. This is simply mounted onto the patient table and can be positioned for any access point, whether radial or femoral access, both left and right. So when you start a robotic procedure, first as the physician, you would load your guide catheter and then have that seated at the coronary ostium. You would then load that into the cassette along with all of your devices, so your guide wire and your rapid exchange catheter. Once everything is loaded here at the bedside, then you would transition over to the interventional cockpit or the interventional workstation. A bedside user would remain at the table in order to perform device exchanges and balloon inflations, but they have a bedside touchscreen to show them step-by-step instructions in how to work with the system. And they can also step away from the table or even potentially out of the room when they're not needed at the table for certain parts of the procedure. And in some studies, we have shown the potential to reduce radiation exposure for the staff in the room as well. Once we're loaded here at the bedside unit, we can move over to the interventional workstation. Here I have a control console as well as my imaging here that's pulled directly from the room that the robotic system is in. At the control console, I have 3 joysticks and 3 touchscreen controls. The first joystick controls the guide catheter, the second controls the guide wire, and the third controls the device. In order to manipulate devices, I can use the joystick to advance forward, pull back, or rotate by simply turning my joystick here. I'll actually sit down to demonstrate this. I can also use the touch screen, which has 1 millimeter movement functions in order to move in very small increments or to rotate my devices in very discrete rotations. And I have enabled on this system Rotate on Retract, which is that automated movement that I mentioned earlier. Rotate on Retract works, as the name would suggest, by rotating the guide wire upon joystick retraction in order to redirect the tip of the guide wire so that as you navigate forward, you can be moving your device in a different direction and hopefully the right direction, which is how we showed that we were able to reduce wiring times. So I can also rotate here, and then I'm going to go, I have a lesion here in my proximal circumflex, so I can drive my guide wire down my circumflex. I got caught in a diagonal branch here. I can rotate my wire to avoid that branch, and then which is responsible for rotating the guide wire. And the system works by holding onto devices and rotating them. The guide catheter is actually moved by the entire robotic guide moving, slightly different than the wire in the device. And then when I close the cover here, all of those devices are being held in place as mentioned earlier. So this is the CorePath TRX system. I'd now like to show you a case that was performed by Professor Jacques from Clinique Pasteur, completing a robotic-assisted bifurcation procedure. And he is located in the control room when he does that. So let's come on over here. Take that. Thank you very much.
So
I will share my screen again.
Yeah, great. That was really wonderful, and it made things look very simple, and the machine look very simple and user friendly.
We intended to make it user friendly. We didn't want to overcomplicate the system. If you can implement it into your daily practice without having tremendous difficulty, we see that as a success, while also, of course, adding value during your procedure. So I will now present the procedure. The case is approximately 9 minutes long. And then I believe after that, Dr. Khanna, we will transition into the Q&A portion.
The key objective today for this case is to perform PCI of the OM bifurcation lesion, which is Medina 011, assisted by the Corendus CorePath robot and using a 7-trench right radial access. And so now what we will do is to advance the first wire in the OM1. Then we will park this wire on the side, and we will advance second wire in OM2, followed by the stent implantation. The robot and the arm, which is already connected on the left radial artery. It's a 7-trench guiding. We have the connection of the catheter, and then now the nurse will advance the wire with a different shape. C'est bon? Il faut tourner beaucoup plus. Hein?
May I ask who introduced the sheath and who introduced the guiding catheter to the circumflex?
To introduce the guiding catheter, the fellow introduced the 7-trench guiding catheter in the left, in the right radial artery, and did a selective catheterization with the left-hand plates of the circumflex. And now we have a good position of the guiding with the selective catheterization. So what I will do is to advance this wire in the OM1, and then I will try to place the distal part of the BMW wire as distal as possible in this OM1. Here we are in the small branch, so I will pull back and I will try to advance a little bit more distal with a loop. It's okay like that. We can leave it like that. Okay. Now I advance the second wire in the distal second OM2. Okay. And now we have the 2 wires in the 2M branch. And now what we do is to advance the stent turbo mode. And here is a stent. It's a 2.518 millimeter stent. So I will place the distal marker just just distal to the lesion. I can advance a little bit more distal here. And now we can open the lesion. So 6 atmospheres, 8. And you see, I will show you that during this procedure, there is absolutely nobody around the table. So that's a great advantage of the robotic. You see, it's to reduce close to 0 the X-ray exposure. I think we can go up to 14. Down. I will pull back the balloon. Okay, I think we are ready for the balloon. And so what I can do is to, you see, with the guiding catheter with my right hand, I advance a little bit the guiding here. Okay, and we see that now we change the position, that the distality of the left hand plats is a little bit more ascendant. And now I will advance the 3.5 millimeter balloon on the wire in order to do the optimal post-dilatation. 18 atmospheres. And now we can stop here. Okay, so now what we have done is the placement of the stent in the OM2. We have post-delayed. Now what we will do is to remove the 3.5 millimeter balloon. So now we are sure that the 2 wires are correctly placed. And what we will do it now is to advance the balloon 2.5 on the first wire, which is now already parked. And the nurse will switch the 2 wires at the table. Don't switch. The major change in our work, it's the first time in my life when I perform the procedure, you know, sitting, total out of the room, so with absolutely no X-ray exposure. You can have the coffee or some drink when you are working. And of course, it's very important to work as a team and to select in the team. And here we have 8 cath lab, so we have more than 30 nurses working clinical cluster, where I have already selected 5 nurses fully dedicated for robotic PCI. And this is very important because I teach them the way, you know, to remove the balloon, leaving the wire in distality, what we are doing manually, this kind of manipulation of the wire. And now the nurse can do it. Or, in addition, you can work with our fellows. Okay, I think we are ready now. We will advance the balloon catheter, the 2.5, in the OM1, in the wire in OM1. I hope that we could cross. Okay, I have to push a little bit more distal. Okay, you see the wire crossed now the lesion. I think yes, we are inside the OM2, and we can inflate at 10, 12 atmosphere or more. 12, 18. Okay, down. So we can take a view again. It's not too bad. You see, I think it's really acceptable. If we zoom on it, I think it's acceptable. So what you can do now is to do the kissing balloon. In other words, we will park this balloon across here, the bifurcation. Okay, perfect. And now we can advance. So we will switch the wire again, and we will advance a 2.5 15 millimeter balloon on the OM2 wire, which is at present time parked, and in order to perform the kissing balloon. And now we will be able, okay, the balloon, you see the didn't move. And now we will advance the small balloon here to do the kissing. 16 on both. Okay, down. So now I remove back this one. The nurse will remove this balloon. The nurse will remove the balloon which is still part. And we will advance for the last balloon inflation in order to use the final part, the 3.5 short balloon in Proxima, that we will inflate in Proxima. I will show you the final view. Okay, this is fine. Huh? I think it's okay. Look.
Yes, it's okay.
Yeah, I think it's okay.
So that was wonderful. I mean, it's really been a very good exposition of a wonderful technology. And the way you explained and the way the case was done, it looked very simple and very doable. And I think that's the beauty of both the operator and the presenter and the technique and the machine, that this probably looks to me that the learning curve should not be very much and very steep. I think people with good amount of, good vascular and coronary skills probably would be learning it quite fast. So thank you very much for these presentations, and I'll open it to the question and answer, and I'll be joined by the chairman, Dr. Jacques Busquet. I think I have a first question, Kate, to you. What has been the learning curve among operators? Because I believe about 10,000 cases have been done across coronary, neurovascular, and peripheral arena. So, what is the learning curve? What is the minimum requirement for training? And what sort of cases are there to start with? I would like to invite Dr. Jacques Busquet also to join us.
I am with you now.
Okay, sir.
Yes. So thank you for your question, Dr. Khanna. We often get asked about the learning curve because, as with any new technology, there is, of course, a learning curve. An early study of robotics showed that a number of different variables leveled off after only 3 procedures, but we feel that the learning curve and the real amount of time that it takes in order to get really comfortable to start doing more complex procedures is more in the range of 20 to 50 procedures. Oftentimes, hospitals and physicians will choose to start with slightly more simple procedures in order to get comfortable with the technology and then work their way up. But in order to get to those most complex procedures, it is not a very significant learning curve. But the important thing to note about this technology, as with any technology, is that practice is really critical. We did a live case the other day with Dr. Lombardi, and he mentioned purposeful practice. The more you perform robotic assisted procedures and integrate the robotic system into your daily practice, the easier and more quickly everyone on the team will be able to use the system, and the more you'll be able to see that value of the technology.
Kate, I'm Dr. Busquet. I have a question for you. A few years ago, I was faculty in Miami with Barry Katzen. Maybe you know this person. He's a very famous radiologist, one of my friends. And he did use, in live case, one system similar to yours. Was it your system at that time?
So I believe the technology that may have been demonstrated was a different vascular robotic technology that was designed for peripheral vascular interventions. That technology is actually no longer on the market anymore. The technology was primarily designed for catheter manipulation. And currently we are the only endovascular robotic system that is designed not only for catheter manipulation, but also for guide wires and therapeutic devices such as rapid exchange catheters.
So you are a leader on the market now.
Yes.
Congratulations.
Thank you.
I have questions on my screen and also on my iPad from a lot of audience. But the first question is, I believe this system of yours is capable for coronary, neurovascular, and peripheral applications. As of now, that means all three of them are working on 014 wire, or you have a upscale on the wire capabilities also of 018 or 035?
It's a very good question. The current generation technology is indicated for use with guide catheters between 5 to 7 French, guide wires that are 0.014 inch only, and rapid exchange catheters. For our neurovascular indication, that also includes microcatheters as well as embolization coils and coil assist stents. But right now, the technology is only for use with 0.014 inch guide wires. So when we start to look into peripheral vascular, where the types of devices are more varied and many of them are much larger, we tend to focus more on a specific set of procedures where those 0.014 inch devices will work well.
In future, is there a possibility that you're going to have upgradation of your wire? The wire compatibilities to 035. I'm typically speaking of when it's needed in endovascular aortic repair and large vessel repairs. But I saw one of the cases in our APFIC conference in June. Dr. Allen actually did an endovascular aortic procedure with 014 wire, or maybe a bigger wire. I couldn't catch that. So was it with the 014 wire that you can do these endovascular aortic repairs, or at present this technology is not suitable for that?
At present, the technology is not suitable for that. That said, we do have a strong research and development team that is in the process of developing new technologies to address new indications, as well as to evaluate the use of different devices during procedures. So simply because it's not capability at this point in time doesn't mean that it wouldn't necessarily be in the future. Our team has been very focused on developing towards future capabilities and technologies that can address different procedures than what we're doing now.
How many centers in US are yet installed with your system?
So there are approximately 60 centers in the United States.
And in Europe now?
Europe, we have a handful. Currently, there are approximately 90 systems worldwide at 75 institutions.
Do you have system installed in China?
Not yet. China is definitely on our radar, but we are not there yet.
You will have a quarantine.
So, one of our question comes from Dr. Gopal. He says, he has a very interesting question. Many of these peripheral vascular interventions, normally we do an antegrade and retrograde approach. So we have two accesses. In those sort of situations, do you use two robotic arms, or you do it with one robot, one by one?
It's a good question. Typically, in procedures where there's multiple access points, one of the access points would be set up robotically, and it would be treated as what we call a hybrid procedure. So when we think about robotics, we don't necessarily think that you have to use the robotic system for every single part of your procedure. We think that even if you can employ the robotic system for different portions of your procedure, that can add value. So in those types of instances where you have lots of devices, you have multiple different access points, that would be considered a hybrid approach and is commonly done currently. The case actually, I believe, that was performed by Dr. Lombardi was an example of that.
Do you think that training of intern resident young in the career can be trained directly on your system, or they should use first the manual procedure?
So it's a very good question. We see in hospitals, academic institutions that implement a robotic program that they often take a hybrid approach where they spend time training on both. And one of our physicians mentioned that really one of the focus areas in the future should be on managing for complications and being able to focus on those and being able to deploy a robotic system in your current practice. However, I think the standard approach for many of those academic institutions and fellowship programs is on training to both at the same time.
Do you think you can limit the complication?
With the robotic system, do you mean?
Yes. Yes.
I think that would be the goal, as that would be the goal of probably many technologies, to limit complications. I think we are have shown in our clinical studies that we are as safe and effective as traditional manual techniques, and the goal would be to show that we can improve upon that, and of course complications would be a part of that.
Thank you, Kate.
There's a question from Dr. Abdul Salam from Bangladesh. There are two questions, in fact. One, whether it can be used for structural heart disease, this technology, and the second one is the cost of the machine and the whole setup.
Okay, so to answer the first question regarding structural heart disease, the system is not currently indicated for structural heart. The system in the United States is indicated for coronary and vascular intervention, and then in other countries, including CE mark countries, neurovascular, but to date, not structural heart. With regard to cost, this is certainly variable depending on your location. I would encourage you to speak with the local team to get specific information, but the capital equipment would be the robotic system itself, and then the disposable equipment, which is the single-use cassette and associated draping, would be a separate per procedure cost. But I'll have to defer to your local team on what exact figures you would be looking at for your location.
That's wonderful. And there's a question from Nigeria. In terms of timing of the procedure, is it shorter? How long, how much more time it takes to do a robotic procedure as compared to do a manual procedure in the cath lab in a usual setting?
So that answer would depend on the level of experience that the hospital has. As you would expect when you first adopt the technology with the learning curve, that there will be some extra time. That's typically focused on setup for the procedure, so draping the device, getting the cassette attached, and loading the devices into the system. But the more practice and the more proficiency that the entire team, the robotic team at the lab has with procedures, the less time it takes. So anecdotally, I've heard certain hospitals that their setup maybe only takes 2 minutes. In a study that was published by Dr. Mahmood of UCSD in San Diego, California, in the US, he evaluated the time with which it took to do robotic procedures as compared to manual in a series of procedures ranging in complexity. And what they found was that the more complex the procedure became, the less time robotics took. So in the most simple cases in that study, robotics took more time by a few minutes. Whereas when you got to the most complex procedures, the type C lesions, that was where robotics was actually equivalent, if not slightly less time than manual. So it really depends. And I would say, as I mentioned earlier, that in order to truly adopt technology, you need to get proficient with it, use it every day, and employ that purposeful practice.
And what do you do in case you have a complication? Do you immediately switch over to manual practice, or you still continue with the robot and try to deliver in covered stents or manage a bad dissection or a left main dissection?
So that would be very physician dependent on their case approach. In certain instances, they may choose to continue to manage complications robotically. If they choose to go manual, the time that it takes to convert from robotic to manual is very, very limited. I can personally, although I will say I have quite a bit of experience with the robotic system, having been with the company for 10 years, it takes me approximately 15 seconds to convert the robotic system to a manual procedure. But with appropriate training, that could be anybody in a case. So really physician dependent and case dependent on how you would approach that, but I think either could be employed.
I think, Kate, there are many questions from all over the world. There's one from Harris from United States. How much does it cost in US? I mean, what's the cost of the machine and the procedure in US?
So again, I'll have to defer to the local team about approximate pricing. The list price for the system is just under, it's about 900 US, 900,000 US, but please speak with your local representatives about what your pricing would be.
I think Dr. Busquet, how do you see this endovascular robotics, the Corindus robot, in your practice in France? I know that you have a very busy vascular practice in Paris. So how do you look at it? And
I'm very impressed by this topic. I'm very impressed by the machine, and I'm very impressed by Kate, because she exposed the system so well that I would like to be part of it if it's available in France next. I advocate for this technique, especially in complex cases. Sometimes, for instance, when you have to catheterize a contralateral limb after exclusion of AAA, sometimes if the aneurysm is big, it's sometimes very difficult to catheterize this contralateral limb, and you can spend 30 or 40, 45 minutes to do it, even if you are a good navigator. So I think in very tricky, very complex or space-related case, it will be very useful. I'm sure that the pricing will go down with the time, and especially if there is a sort of a package when you buy a suite and this system together. Probably they will have some package dedicated for the investors. I think that person like yourself, Dr. Khanna, will be the ideal utilizer for such a system. And I encourage you to pray for your investors' decision.
I totally agree, Jacques, because sometimes not only wiring the contralateral limb, but also, if you have to embolize internal iliac prior to the procedure and in a aneurysmal common iliac artery or external iliac artery, it becomes very difficult to actually embolize and localize those vessels. And I believe with this sort of a robot, it probably should be quite simple, as you have different functions for advancing the wire, and you can adjust the angulations, and you can be very precisely getting into these vessels. I believe I have a feeling that probably it will have a niche in that area. It will also have a niche in pudendal artery stenting. We are one of the biggest centers in the world doing pudendal artery stenting, where it becomes very difficult to actually negotiate wires and pass in the hardwares into the pudendal arteries. You have to be very precise.
Dr. Khanna, do you think that this system could be useful in a prostatic adenoma embolization?
Yes, that is what I'm saying. It will be very good in the pelvic interventions in terms of vascular intervention, pelvic arteries, penile arteries, prostatic embolization, the venous leak syndromes. It probably would, that is where it will probably have a very big niche. And those are the things which probably move much better on a 014 wire, and they're really tortuous and complex anatomies. This system would work probably very well there. I have a feeling.
Dr. Khanna, do you think you will get the system for your next meeting in June next year?
I really hope so. I would, that's why, we need the support of our hospital and our chain. I think we should. And if it had not been a Corona time, probably it would have been easier, but I am very hopeful we'll get one. And maybe by next topic, we'll show you a live case on robotics, endovascular robotics.
I support personally your demand.
Kate, there's another question. This one is from UAE. What is the role of robotics in crossing CTOs and treating coronary CTOs? Is it indicated, or it's not? Those are not the type of patients we should be taking up for robotics.
So it's another good question, and we have a prime example, and I've mentioned it a couple of times, but I think it was a really great example. Dr. Bill Lombardi from the University of Washington in the United States performed a live virtual case as part of our GRX Live course program just 2 days ago, and he showed a CTO case. And in those procedures, the approach that physicians take, we have a number of physicians that use this approach, it has been published as well, is to do a hybrid procedure, planned hybrid procedure, where wiring and use of CTO devices is completed manually, and the remainder of the procedure is done robotically. And Dr. Lombardi himself cites that in his procedures, he's actually seen that he is away from the table for approximately 40%, which is really not only reducing his radiation exposure, his orthopedic burden, but it is also providing him the value of robotics for at least that 40% of his procedure that he's doing. So the answer is yes, it can be employed. It would be considered a planned hybrid approach. And I would encourage you to take a look at some of our peer-reviewed publications that can be found on our website in order to learn more about how physicians are using this in practice for those cases. And I will say that live case that I've mentioned will be on our website, our educational platform, roboticpci.com, within the next several weeks.
Kate, I would like to add that Dr. Lombardi, that I know personally, is a very famous doctor and very respected. I met him several times during TCT. He's a very good debater and a very good operator. You have the chance to work with him. Thank you.
Yes, he's been a tremendous early adopter of robotic technology. He will be presenting at the TCT Connect conference on robotics during both our Corindus Symposium as well as a symposium being held by our parent company, Siemens Healthineers. So we're excited to have him share his experience.
We will click on this program.
I think the interest generated today has been tremendous. There's another question from Indonesia. And the question is, what about primary PCIs? Is anybody in the world is doing primary PCIs by robotics, or is it only for stable patients?
It has been used in both, and we have had a number of case examples, and believe there might be a case report on our roboticpci.com website demonstrating the use. And again, that would be another one that would be physician discretion as to whether or not they're comfortable. And certainly the more experience that you have with a robotic system, the more comfort level you may have in being able to use the system for primary PCI.
So I think this brings us to the end of this symposium. So we are right on time to start as well as end. It's been a wonderful symposium. I must really thank you personally, Siemens and Corindus, for this tremendous, educational activity. I have no words of, I can't be more appreciative to our joint MD, Dr. Sangeeta Reddy, and DMS, Dr. Subramaniam, for encouraging us to actually push for this technology and the vision which Dr. Sangeeta Reddy actually gave us for future, adoption of future innovations in Apollo healthcare system. I think this would probably help us to build a big program or robotic endovascular and coronary interventions, not only in Delhi, but in many centers and Apollo centers in the country. And I hope as the future comes, with the advancement in technologies and upgradations in the Corindus technology, probably in future we'll have a compatibility of 035 as well. And probably then we could be doing any procedures from head to toe and any size of vessel with robotics. And I'm sure with more use of robotics, we would be looking at precision medicine and also a remote precision medicine and utilization of our expertise, where people would be differentially and preferentially trained in different techniques, and they could share and do cases in different healthcare facilities across the country or across the world. So I'm sure this is going to be it is a very important technology, and this could be one of the game changers in the way interventions are done in future. And of course, it would definitely reduce the radiation and the orthopedic burden on our operators, which is a very important thing now. And we have seen, sadly, we have lost many of our interventionalists in the last 2-3 years because of cancers, and especially on the left side of the brain. And this technology is a very welcome technology. And I'm sure the newer generation of cardiologists would train in this, and this will become the standard of care. Thank you all very much for attending this webinar. And thank you, Kate, Corindus, and Siemens. Thank you very much. Thank you, Dr. Busquet, for sparing your time and being a tremendous support. Thank you.
Thank you both for having me.
It was a pleasure for me. Thank you.
Bye-bye and namaste.
Bye-bye. Goodbye.